Now it's on to our first session, Development and Deployment of Mathematical Models for Operational Management of COVID-19, featuring Professor Jose Blanchet, who will be interviewing Professor Peter Glynn and adjunct Professor David Scheinker. There will be a Q&A immediately following their discussion, so please, without further ado, I welcome Professor Jose Blanchet. Feel free to take it away.
Hello. Hi, good morning, good afternoon, good evening. We are connected from different parts of the world. My name is Jose Blanchet. I'm a professor of management science and engineering. Thanks, Pam and Linda, for the introduction. I happen to also be an alumni of MS&E. I got my PhD in MS&E in 2004. And so I always love these types of events, especially when they are in person. Hopefully they will be soon back. I get to see friends and former classmates. So I hope you are here. Welcome. Today we are going to talk about. It's my pleasure to be a part of this panel. I was asked to share what some of the activities that we did at the beginning, and really these activities were driven by David and Peter, and so I thought, why don't we talk about those activities? So it's my pleasure to have them here. You all know, perhaps you know them well. Peter is a member of the department, a senior member of the department for many years. He happens to also be my PhD dissertation advisor when I was a PhD student. He is somebody who has contributed enormously to the operations research community, in particular in areas related to applied probability and stochastic modeling. Peter is a member of the National Academy of Engineering. He has won many awards, and he also is a person of great human quality. So when everything started in the pandemic, we got very interested in trying to kind of like help in whatever we could, and Peter was a very early driving force of that. The same I can for David. David is not only a faculty member of MS&E, but he's also a clinical associate professor in pediatrics, endocrinology and diabetes. We are extremely lucky to have David also as a part of our MS&E faculty. He has been an amazing bridge, and we are going to talk about this during the conversation. David is a pure mathematician by training. He did his PhD in mathematics, and now he's applying all his talent in solving problems at the intersection of operations, research, and hospital operations, and also developing research that aids in clinical treatments. So that's this combination is part of what we are going to discuss during these few minutes. So what I would like to have is a sort of unscripted conversation, but is guided by some questions. So you're going to see looking back and forth for me in my screens, because I want to make sure that we cover all the topics. So welcome, Peter and David. And so, fantastic. So, and I'm going to start. I would like to start with the first kind of going back. I'm going to try to go back chronologically, the beginning. So every operational problem typically brings interdisciplinary work, right? Interdisciplinary challenges. So I would like to start talking about the challenges that surfaced at the very beginning of the pandemic. Let's start kind of like thinking back about that, so that we can share with our friends the sort of process we had to go through, and I would like to kind of talk about that, the problems, data collection, forecasting. So why don't we start, kind of thinking back? We are in that place, and let's talk about that conversation.
So I think it's worth going back to January and February of last year and thinking a little bit about where we were at that time. So in particular, January and February, we knew very little about transmission of the coronavirus within the United States. We had very little testing going on at that time. What we had heard were reports from China, and we're getting early reports, for example, from Italy. And so we didn't know much at that time about the rate of infection, how infectious the coronavirus really was. We didn't know much about, for example, typical stay durations once people were hospitalized. We're just in the early stages of gathering that kind of information. And as it became clear in the beginning of March that the United States did have a serious infection problem in California in particular. In fact, I think one of the early cases that we had here in the United States was actually in Santa Clara County, of course, the county in which Stanford is located. So we had local concerns, and the epidemiology of the disease was not well understood at that time, but there was a clear understanding as the disease began taking off that it could have very, very serious implications potentially for the Stanford hospitals and for Santa Clara County and California and the United States in general. So that was pretty much where we were, I think, at that time. So the hospital leadership understood that there were potential concerns. There was I think, a interest on our part to be able to contribute to all of that. And in particular, the expertise that Jose, David, and I have in areas of simulation, stochastic modeling, things of that kind. We understood that potentially that could be helpful in addressing some of the issues that the hospital leadership would have. And David, I'm very, very pleased that David is an active and important member of our department. He was somebody who was brought to Stanford while I was department chair. I think that was a wonderful opportunity for us to be able to bring David to Stanford at that time. And of course, I never anticipated that we'd have something like a coronavirus that would develop. But as it turned out, having David as a intermediary between the engineering school, MS&E in particular, and the hospital turned out to be very, very important in this case. So I'll let David say a little bit about what happened at this point.
Thank you, Peter, and thank you, Jose, for that kind introduction. It's been an honor to be at MS&E, along with my appointments in the School of Medicine and at the Children's Hospital, which, as Peter mentioned, he had the kind of foresight to help create almost 6 years ago now. And the art of working effectively in medicine is really about figuring out how to translate some incredibly messy problem with all sorts of constraints that somebody who hasn't worked in medicine might not even realize exist, and components of the objective that, again, people working outside of medicine might not know about or might not even believe are real components of the objective, because the system is so messed up in so many ways and includes so many perverse incentives. And this is in the best of times. So when the pandemic struck and anecdotal reports started coming in relatively early that hospitals in Italy were being forced to triage, to turn people away because they didn't have sufficient ventilator or intensive care capacity, essentially telling people to take their chances when their chances weren't good, there was an immediate sense of pressure on hospital leadership and School of Medicine leadership to understand how to respond here to prevent that from happening. And at the same time, a situation that Peter mentioned was uncannily scary due to a total lack of data. The standard of evidence in medicine is so high for people to feel comfortable making decisions, even making plans, that when there are so little data available and so little is known, it exacerbates the challenges. Not only do you have the practical decisions you have to be made, but you have to assuage people's concerns that there is anything that can be said in such an absence of reliable data.
Yes, great. So that's right. I remember during the first days, we're trying to understand even basic problems such as definition of objectives, right? What is it that we wanted to, how we wanted to help, trying to gather any information we were trying to, find that was relevant for the tasks, and the tasks were not really, well-defined, issues about forecasting, staffing problems, right? That were the concern, and also like potential problems that could come down the roads. So what do you do? Let's think about you're in a situation like that. You want to help, and what do you do in those cases? You know, in a situation where the data is just not very reliable, in a situation where we, you know, the epidemiology models, and we are going to talk about that a little later, even though this is not the expertise of operations, but you know, we're going to talk about how these things are connected. But what can you do in this early situation where really there is no data, or there is very, very minimal data that you can actually trust?
So I think that one of the key things that we did early on, as you were pointing out just a moment ago, Jose, is we did have extended conversations with people within the hospital. And we were very fortunate also to have the direct expertise of Kevin Schulman, MD at Stanford, who was very heavily involved in all of those discussions. So we did get guidance, as you know, from people connected to the hospital leadership about what types of tools might be useful. Became evident early on that one tool that would be very valuable to the hospital would be to get some sort of sense as to what the likely hospitalization numbers would look like in the intensive care units and acute care units at Stanford in the weeks ahead. So, for example, understanding what would the likely load in the hospital look like 2 weeks into the future, 3 weeks into the future, and so forth, so that the hospital leadership could begin thinking about whether they needed to do a surge in capacity, potentially build some facilities out into the parking lots. A lot of things were being discussed at that time, potentially using even some of the university dorms to handle patients. So things were very, very uncertain in terms of the scale of what would be necessary to respond to this. We also, I think, understood early on that you know, we would not be able to build highly accurate prediction tools. Having a good prediction and getting that to the hospital leadership relatively early would be much more valuable than a sort of waiting for the data to come in and trying to create something much more precise. So that was, I think, a guiding understanding that went along with a lot of model building and the sort of simulation tool that we ultimately created. We did have the ability to get early data, I think, again, through Dr. Schulman from Italy and China with regard to what the early hospitalization durations typically looked like for patients. And we were able to build a simple simulation of how long COVID patients would typically stay in the hospital. And of course, if you're looking at hospitalization numbers, it's not just the infection rate that drives that, but it's also how long do people stay in the hospital once they're hospitalized. There's a big difference between a disease where people spend 5 days in the hospital versus a disease where people are spending 20 days in the hospital. And again, a lot of the early data indicated that there were large numbers of patients that were spending 20 days plus in the hospital as a result of COVID. Those are some of the things that I remember as being important in that phase.
Right.
So the things Peter talked about, they actually highlight incredibly well the benefit of this engineering school of medicine collaboration, because early on, there were a lot of national level forecasts about the hundreds of thousands or the millions of people who would die if measures weren't taken, or about hospital systems that could be overwhelmed. But those high level forecasts didn't offer really practical guidance for the kind of local decision making that people at our hospital or people in our county or people at the California Department of Public Health needed. And one of the earliest things that our conversations with our partners at the schools of medicine hospitals helped was to identify very specifically, what are the decisions you're going to have to make soonest? What do you need to know in order to be able to make those decisions, given all the uncertainty? So for example, calling in additional nurse staffing or additional physician coverage or canceling elective procedures were probably steps that would be taken soonest if our capacity started to become overwhelmed. Whereas steps to expand the physical capacity and other more drastic measures would actually be moot if the staffing capacity to support that weren't available, or if the ventilators or the ventilator support for that wasn't available. And so helping people kind of calm down and understand that although there's 1,000 things that they're imagining and worrying about and considering as potential problems, and focus, okay, let's just order the decision points and prioritize the information for those, helped bring structure to something that otherwise was just scary and unwieldy. And I'd be remiss if I didn't mention that Nigam Shah and Kristen Stoudemire were two other faculty from the School of Medicine that did fantastic work, along with Kevin Schulman and also Dr. Andy Shinnon working. This was an incredible team effort where people came together very quickly and all just contributed unselfishly.
Yeah, thank you for mentioning those other physicians, David.
Exactly. Right.
Team.
I mean, sorry.
I was just saying that it's really important to recognize just what a large team of people it was, and all of these other people at the hospital that were contributing. And I think every day for probably a period of probably 10 plus days, we spoke as a group, and the group was probably a dozen people on a Zoom call, trying to understand how to build this model, what pieces of information people had, and what pieces of information could be brought to bear. And having all these physicians at the hospital and in the medical school just were an enormous asset. And of course, that connecting with those people quickly was possible, really in large part because David has been such a valuable asset in terms of both developing tools himself, but also creating all of these wonderful connections with the hospital, with the medical school.
Right. Yeah. This was really sobering for me. Like I think is this research experience in which everything had to be put together very, very quickly. And sometimes in academia and academic research, you can take your time. You can think about problems really, deeply. And this is one situation where you have to, leave what you are doing, come together, and try to really build very, very practical solutions, right? So in addition to the great collaboration with the medical school, I also remember the PhD students, right? So many of our PhD students, or several of them, at least in our group, in others as well, they rose to the challenge, right? And that was also very, very inspiring to see that they really also played a significant role in building all of that. Don't you agree?
Inspiring is the word, and it was amazing what these students did. We had probably a half dozen students that were heavily involved with this project from the beginning. And ironically, one of the students who played a very critical role was actually a student who came from Wuhan in China. Wuhan, of course, is the city in which the coronavirus first developed, and it was very, very heavily impacted, particularly in the month of January, first part of February. So at that time, Jose and I were talking. He's one of our joint PhD students. At that time, we were talking to Tung on a regular basis, asking him about how his family and relatives were doing. We didn't fully realize at that time that would be coming to California, to the Bay Area. But indeed, he and the other students understood just how important developing these tools quickly was. And they put their regular PhD dissertation work aside temporarily. And they were working very, very long hours to try to create this tool in a very, very short time frame. And I think that from maybe day one that we began discussing the development of potential tools for the hospital to the time at which we actually rolled out something that Kristen could take to the hospital leadership. And it was a very short span of time. I think maybe within 2 weeks, we had something that the hospital leadership was using. So this really was a situation where time was at a premium, and the students were really how that happened at the end of the day. So I really give a lot of credit to our students for the energy and the effort that they put into this.
And actually, to highlight the importance and how quickly the students work, you should also mention that at the same time, in parallel, using the same infrastructure, we were building a county level hospital projection tool with many of the same students and other PhD students, Johannes, Isha, Raymond, Lin Ying, Jin, where we wanted to figure out, using the one data point that really seemed reliable at the time, the disease severity correlated very, very strongly with age. And so using the age distribution of different counties, we could try to quantify how vulnerable the populations were. And then combining that with the hospital capacity of the county and the hospitalization rates thus far, we could provide a calculator. It wouldn't generate projections over many months of the kind that were being published at the national level, but it would help local decision makers and the California Department of Public Health try to have a simple what if scenario analysis tool. And that was also rolled out over this same 2-week period. The first version was really incredibly rapid work by the PhD students. And we can't give them enough credit. And if I'm forgetting any of their names, it's only because there were so many who worked so hard that it's hard to keep straight.
Thanks, David. Yeah, that's right. I mean, you have touched on topics that I want to also discuss, which is, the type of input that is needed in developing these mathematical models. We're gonna get to that. And as we build, this conversation, for me at least, is the only sort of like research experience in which I have had the sort of like a intense sort of time pressure of trying to kind of do something that is useful. And I do remember these meetings every day, monitoring the search of patients and the conversations with the hospital, and that was really kind of like a unique experience, at least for me, research-wise. And yeah, I mean, you touched, so to recap, so what happens, right? So at the beginning, you have this need, because of the experience that has happened in different cities, in different parts of the country, you recognize that there is an impending risk for the hospital, right? And that there is no data, but there are questions, for example, about the staffing, about the use of ventilators, about the resources, and questions that really, from the outset, you don't really think might impact that much. But of course, the scheduled operations, right, downstream, elective operations that support the hospital, and you also need to, you need to also cope with the constraints and the requirements of the use of the hospital for normal operations. So you have all of these constraints. You have the uncertainty of in the data. You have no data, and you have the recognition that resources can be overflown based on experience. So what do? You quickly come together. You talk to physicians. You talk to the hospital. You understand the constraints. You try to build models as quickly as possible, using queuing theory, because that's the language in operations research that allows to do model systems with resource contention, Monte Carlo simulation based on randomness and distribution. This is what the students were doing in these couple of weeks, and this is where we are now. So now, as we go and try to kind of feed these models with more, data that is connected to the epidemiology, right? Let's talk maybe a little bit about that. You touched on that, on that type of information and those types of models. And then let's talk, and I'm gonna come back to another point that you touched, which is how this also impacted not only Stanford, but the county. You talk a little bit about that, and I'm gonna come back to that. And I'm going to go also later downstream in the conversation is outside the county. So Stanford, first, or group or students, right? How we start, how the people came together, how, and it's unique, right? Type of experience, the conversation with the hospital, how the model builds. And then I'm going to expand to, other teams that feed into models. So let's talk a little bit about this epidemiology. Some people have heard perhaps or alumni about, SIR models a little bit, let's maybe, even though that's not of area of expertise, it will be useful for them to know that stuff, we need to be aware of that stuff and how do we use it. So why don't we talk a little bit about that?
You raise a very, very important point. Early on, I think we understood that we should not try to replicate the very valuable work that epidemiologists have been doing all the way through this coronavirus epidemic. So, but the problems that the epidemiologists face are also problems that we need to understand what the issues are that they're dealing with, where the uncertainties are in their model and so forth. So it's worth, I think, saying a little bit about what an SIR model is. So an SIR model is a model that is a so-called compartmental model. You imagine the whole population is separated into three groups: susceptibles, that's the S, I, infecteds, and R for recovereds. And the model basically is a deterministic differential equations model, a nonlinear differential equation to model the interactions between infecteds and susceptibles. And that model has time-dependent coefficients in general that would reflect, for example, the rate of infection. The rate of infection is going to be driven, of course, by social distancing. There would be a rate constant in there having to do with how long it takes people to recover. There would be also information built into the rate constants having to do with just how infectious the coronavirus disease is in the absence of social distancing measures. So the epidemiologists are taking into account all of these different factors, and having said that, these models are an oversimplification. Everybody recognizes that, and in particular in the early phases when we didn't even know really just how contagious this disease actually was, there was enormous lack of understanding of just the how challenging the coronavirus might be, even in the absence of social distancing measures. We didn't have an understanding of how successful the social distancing measures would be. So, even imagining that you would get these rate constants accurate within a factor of 2, that's already, I think, an enormous challenge, particularly in the early phases of the coronavirus pandemic. So as a consequence, when you run these models, you're not expecting these models to predict in a particularly accurate way. And you could see that in the early phases with the different models that were being proposed by groups around the country. There was enormous variation from one SIR model to another in terms of just how many infecteds you'd have, for example, in Santa Clara County. And when I say enormous variation, factor of 3 or 4 between the low estimate and the high estimate, projecting out over even a time period as short as a couple of weeks. So that gives you some sense of the challenges that the epidemiologists were facing. Having said that, I don't think we could have done any better in making predictions ourselves. So we just used the, what was coming in from these SIR models that have been developed by groups with more expertise than ours.
Yeah, this was a really challenging tightrope to walk. There was a lot of good faith effort from all over the world coming out to study this and make data available. And there was also just nonsense and misinformation coming out, some of it even from Stanford. And we wanted to be very careful that we didn't go and make claims that we didn't feel confident in or that weren't beyond our expertise. For example, erring on the side of caution has real consequences. Even though people canceled elective procedures, a lot of elective procedures are something like the removal of a tumor. Even though it's not urgent, it's non-discretionary, and there are real human costs to delaying the medical care that would be provided if you put everything else on hold. Above and beyond that, our tools would only be useful if people trusted them. And if we overstepped our data and the things we could forecast reliably and lost that trust, then the tools wouldn't be any use at all. And this was an area where Joshua Salomon, he's an epidemiologist, worked really closely with us, who's speaking about the value of collaboration. I think we met because He's the husband of one of my colleagues with whom I worked closely at the Children's Hospital on another aspect of the problem, the personal protective equipment, PPE. And so he was this serendipitous connection to help us make sure that we built only the minimal assumptions required to help people use these calculators, these tools to facilitate operational decisions, and really didn't go beyond what was necessary and what we felt comfortable would actually be helpful.
Great. Yes, that's right. So this gives the sense of when we talk about interdisciplinary work in a very short amount of time, you can quickly see it's about team formation. You know, the teams that are going to work in the problems on the side of MS&E operations, the communication with the teams at the hospital, you know, interaction with the epidemiology team, the information that we gather, and deployment as well of the policies. And this was really something that I saw was very, very challenging. So David, you mentioned and something that is important to keep in mind, like in this situation, the reason these variations are you know, are so impactful, the variations in the estimates. These models project in short time scales, exponential growth, right? As everybody learn, and therefore, you know, having misestimating these rates of infection by a factor of 2 can really have, you know, huge consequences. So this erring on the safe side, you know, that might imply a significant gap, right, in terms of operations. But and this is one of the decisions that you mentioned had to be made. You also touched, David, on you know, the relationship with the county. You know, and this is a part of the conversation that I'm actually more genuinely interested myself. The other stuff, you know, I was able to see, and I would like to kind of, you know, also share with our alumni, right? So the role that the Stanford played in the county, you know, the hospital, and maybe you can share a little bit, or Peter, a little bit about that. That perhaps is of interest as well, like, you know, how these models, how these efforts eventually, you know, potentially impacted decisions at that level, you know, more locally, but outside of Stanford.
Absolutely. Yeah, I think as we moved in through February and into March, this is when reports of the hospital system in New York City coming under duress and their hospital capacity being overwhelmed started to come in. And this was also when reports of just, you know, things going terribly in New York City started to really frighten people, where hospitals running out of personal protective equipment, hospitals were running out of places to store the bodies of the deceased. And the California Department of Public Health needed to understand how they could help allocate resources across counties. There were a couple of things that, even though people should know, remain terribly difficult to coordinate. Basic capacity information, such as the number of hospital beds and ICU beds in each county in California, are incredibly hard to come by and unreliable from many sources. The data on the numbers of hospitalized patients in each county and the vulnerability of the population based on the age distributions, though these are available in different places, they weren't available in a single place combined for the purpose of examining scenarios and facilitating capacity planning, and which was one of the first things that we used our county level projection tool to help. And then conversations with the California Department of Public Health, we tailored the outputs of the tool and the inputs and the assumptions in order to give them a way to make standardized estimates and standardized scenario evaluations about every county in California, of course, including Santa Clara.
Because we are running out of time, I also would like to, just close the conversation with beyond the county, right? So I know we and especially the students, you, Peter, created these tools that are up in the web, and that were available for other hospitals to use. Maybe you can share a little bit about that. And now I think if I look at the program, and I don't want to delay a lot the Q&A session, so we can talk about that, and therefore kind of like close the conversation with this sense of starting from small, the challenges, and kind of seeing MS&E in the department kind of like as a beam of light that try to help during this pandemic and everybody come together. So why don't we now talk about this more broad sort of like a contribution, in addition, of course, of the papers and the white papers that were produced.
One of the things that we did in creating these tools was by, on the basis of the factors that we discussed earlier, these tools necessarily needed to be stripped down into a form that was easy for hospital management to understand and interpret, and taking advantage only of very basic information. There was no point in building enormous model sophistication given how poor the data was. And that means that potentially this kind of tool can be widely distributed to other hospitals. And as a consequence, with all of the different projects that we were involved with, there were 3 different projects. There's one more project that involved personal protective equipment that we also developed. All these tools were developed with the idea that they could also be distributed to other medical centers and hospitals. So we implemented these things in a tool called R-Shiny, which makes it easy for other hospitals to potentially use. And I have a nice story that, in fact, I have an undergraduate that I'm working with this quarter on a model extension to one of the tools that we developed, who is an undergraduate who is currently studying from home due to the pandemic. His home is in Salt Lake City, and he came to me earlier this quarter because he'd been exposed through the Salt Lake City medical system that he was interacting with to the tool that we had distributed to help understand hospital capacity issues, the simulation tool that I alluded to earlier. So these tools are getting wide distribution. That's something that we're very, very happy to see occurring. And I think they get, these tools are successful in part because they are intended to be relatively easy for hospitals to use. And we're built from the beginning with that in mind.
I'll add only that even though we focused on building tools that would facilitate very specific decision solving at our institution and our county, it turned out that those decisions became so central for so many places that we actually had people reach out to us from hospitals all over the country, and actually people from other countries reach out, Israel and Canada, to extend some of our modeling, which I think shows the power of operations research, that if you identify the most appropriate decisions to focus on and pour all your effort into facilitating and proving how those decisions are made, then even without the initial intent to create something broadly generalizable, it still becomes a vastly useful product.
Thank you so much, Peter and David. Thank you for the conversation. I know that we are a little late, Linda. Apologies for that, but I think this was a very productive discussion. Hopefully, our alumni will have questions and have had a big picture sort of idea of the work it has taken to respond to the challenge from the hospital operations side.
Well, thank you, Jose, Peter, and David. And now it's on to the Q&A. So our attendees and alumni have been submitting questions throughout the session, and we'll try to answer as many questions as we can given our time constraints. So hopefully you can answer a few of these questions. So the first question for you guys is, in such a high uncertainty, what systems are in place for sharing information and modeling techniques, or were a lot of systems created as needed?
Yeah, I think a lot of systems were immediately created as needed. I remember the academic research group out of Johns Hopkins, who were collating the number of cases from all over the world, just made all their data available on GitHub. The New York Times used their vast reporting apparatus to collect more detailed county level data like hospitalizations, not just cases. And we, and probably many others, emailed them requesting that they share their data publicly, and they ended up doing it as well. So everyone from research universities to publications like the New York Times were making data available actually far sooner and far earlier than official agencies like the CDC had time to bring something up.
So the next question is on the data input point, beyond asking sources such as hospitals, et cetera, directly, any lessons learned about filtering noisy data in large data aggregators?
Yeah, I mean, I remember there was this case where using data from the American Hospital Association, we got estimates of the capacity of hospital beds of every county in the US. And then when the California Department of Public Health shared their estimates, there was one county where the estimates disagreed wildly. And the California Department of Public Health estimates were something like hundreds and hundreds more beds than were actually there due to some artifact. And it was only because of the experience of somebody on the team to realize that couldn't possibly be correct, that this was identified and resolved. So it became this art form of collect data from wherever you can, and then have experts look at it, and then find more kind of paths along your detective work to understand how you can resolve issues.
That's also something.
Ahead,
no, I was going to say that as a consequence of that question sort of hints to, what comes next, right? So there are several kind of important problems and lessons that we have learned as academics, and precisely this, how to deal with very noisy data quickly, and how to, filter out, denoise the data from coming from different sources. That's a sort of question that is there now for academics to study, right? With in a more general environment, right? But yeah, the beginning, as you say, David, is like it was just the experience of the team, because you have to respond quickly, right?
And that for such a practical project, there was actually like a really subtle and interesting technical problem of endogeneity, where all of the places from where data were coming on how long hospitalizations were also the places that were overwhelmed by the explosion of the pandemic, Wuhan, parts of Italy. And so you had to ask, how are these observed estimates of hospital length of stay being affected by data coming from a place that's overwhelmed, and triaging, as opposed to a place that's not yet too far along the spread?
So the next question is, can you talk about how to infer data you need by building bridges from data you have?
Can you repeat the question? I didn't understand the question.
Can you talk about how to infer data you need by building bridges from data you have?
Well, yeah, so one example is we need to know the vulnerability of the population. And early on, we saw that the age structure of the population was one of the strongest predictors. So we combined that with the empirical estimates of the age distribution of our counties from the CDC, which were actually available and reliable. So it's a combination of the empirical data you have and those associations about which you have some confidence is one straightforward approach.
Gotcha. Another question is, given that leading epidemiologists have warned about global pandemics over 20 years, why were we unprepared to deal with this one when it arrived?
It's getting political.
I can pass the buck in a way. There's a well-written, incredibly well-researched article from the New England Journal of Medicine editorial team called "Dying in a Leadership Vacuum" that articulates a lot of this from people who really have the expertise to answer that.
Gotcha. Thank you. So the next question is, what approach did you take to validate the models? How effective was the validation?
Oh, we definitely looked at validation issues, and we've continued looking at validation issues in the months since March, April. In fact, we actually had in the Bay Area and in the Santa Clara County, of course, another enormous surge in December, January. And so we were asked again in December, January to help support the hospital leadership in understanding the surge issues that the county was addressing at that time. And so at that point, we had a number of months of data. One of the things that we were able to do at that point was because we could see the forecast errors from the different epidemiological models going back in time. We're able to ascribe forecast errors to each of the different forecasts that were being used. And that, I think, has helped improve the quality of the estimates that we can make available at this point. So that's something that is available when you have more data to look at, when you can sort of look at each epi model and assess how much forecast error they're typically producing. And so that's been very, very helpful this time around. It was not something that we could do in March, for example.